At the core of today's hearing is a controversy about the efficacy of mammography and screening. Stepping aside from that, is the advice that you're giving to women today to continue the screening, is there other advice you might give in terms of perhaps starting younger in terms of screening, or a different approach to it that would avoid this question of the efficacy of the test and the statistical debate we're having today?
No, Senator. I think that we've set the threshold at 40 as what we believe to be the optimal or reasonable level at which we can recommend it and apply it. Now, again, the research that I alluded to earlier in terms of understanding the disease will hopefully lead us to be able to identify women that are at much higher risk than normal or average. And in those women, we may need to modify or change the recommendations as we go forward so we could detect them even sooner or earlier. But that is a work in progress and not yet reached the point where we can make it a uniform recommendation.
Now, you have experience on several different medical conditions, cancer, et cetera. Is there similar controversy in other areas, for example, in terms of prostate cancer or other cancers, where the testing regime and the efficacy and the efficiency are also debated as they are with mammography?
Yes, sir. Unfortunately, there is, and I personally was deeply involved in the issue of formulating guidelines for men for the use of prostate-specific antigen. And as with mammography, in that situation, there's even less data or information upon which to make hard, specific, scientific recommendations. But I think what we are faced with as clinicians responsible for the lives of patients with cancer is to apply the science, but then at the same time use clinical judgment and arrive at the best recommendation we can today, given the information that we have. The information in mammography is far better than the information for PSA and prostate cancer. And we are basing a recommendation to American women on what we have available as the best information.
But I would suspect that both of these areas have helped in terms of your analysis by having experience in several different fields has helped inform your judgment about your recommendation today.
Well, what's most gratifying to you and to us is the fact that in both these diseases we are seeing a decline in mortality. We are seeing a decline in death rate. And that gives us hope and a bit of comfort that we're at least on the right track. We're nowhere near where we need to be, but we're heading in the right direction.
Finally, Doctor, you indicated in your testimony the disparity between the incidence of breast cancer in African-American women and in white women, Caucasian women. What role does mammography play in this disparity, and what might be other contributing factors?
Well, there are two very interesting observations that can provide or shed some light on the answer to that question. One is we are beginning to see the gap narrow between the mortality rate from black women and white women. So we're improving, we're closing that gap, and we're making progress. And that coincides with the fact that there has been greater utilization of mammography among black women. So hopefully those are coincident. I cannot prove them to be cause and effect, but they are coincident, and they are both encouraging.
Thank
you very much, Madam Chairman. First of all, for having this hearing, which I think is so important today, but for your long time work on the issue of breast cancer. And we've been here before debating this issue. Senator Hutchinson remembers, and frankly, we've been through it too many times. And I think the bottom line is women need to know what they can do to fight breast cancer. And unfortunately, this debate too often comes down to a debate between numbers versus women. And we've allowed abstract statistical data to confuse and distort the issues. So I want to thank all of the witnesses who are here today, especially the advocates, for the tremendous work that you do on behalf of many women, and appreciate your continuing efforts to make sure that women have access to early screening and diagnosis. Madam Chairman, it just seems to me, unfortunately, that we have allowed this controversy to shift the focus away from prevention and access to health care. This isn't just an issue for women who are in their 40s or 50s, but for women who are in their 20s and their 30s who want to know what they can do today to prevent breast cancer. And I hope we don't lose our focus on that issue. And one of the issues that concerns me a lot is that we do know through better information and access, more women are getting regular mammograms, and we know that has helped to boost survival rates. But we also know that access hasn't improved equally across the board for all women. Minority women have a much lower screening rate. In fact, the screening rate for Asian and Native American women really is dismal. And I know there's a lot of factors that contribute to those low rates, but I am very worried that the current conflicting and confusing messages aren't going to help our efforts to expand access. Doctor, if you can just tell me what you think we need to do to make sure that this current controversy doesn't hinder our efforts to improve access for minority women, I would appreciate hearing your thoughts on that.
Thank you, Senator. We have tried to be very clear in our message so that we did not continue to contribute to some of the concern. At the same time, we are paying a great deal of attention within the National Cancer Institute, particularly through Dr. Reimer's division, regarding messages and communication and education so that patients do, in fact, have appropriate and timely and accurate information. And we're learning and studying how to reach out as effectively as we possibly can to varying communities so that we can provide that appropriate message.
I think that's extremely important to do, especially when information comes out that's conflicting. It automatically offers women an excuse that they're looking for. And I think we need to really, especially now at times like this, reach out again and make sure we are doing and saying what we need to do to make sure women get screened. We'll make one other comment and question, and that is that I think there's another issue that's really been ignored in this debate, and that's the role that mammography has played, not just in improving survival rates, but in improving quality of life for breast cancer victims. And the written statement of Dr. LaFalle, who's the chair-elect of Susan G. Komen Breast Cancer Foundation, shows that because of mammography, tumors have been detected earlier and smaller. Now, that is a huge benefit that I think has been lost in this debate, because options to mastectomy significantly improve the quality of life and allow for a faster and quicker recovery. Can you talk a little bit about how mammography and early diagnosis has impacted quality of life for breast cancer patients?
Thank you for pointing that out. And I think from the quality of life point of view, over and above just the mortality argument, discussion that we've been having, that from a patient's point of view is an extremely important contribution. By detecting cancers earlier, one can then apply therapies that are going to be less mutilating and less have less of an impact on the quality of life, and that in itself is a major goal and objective for us. So I concur completely with your emphasis on that particular aspect of the issue.
Well, thank you.
To give you the real background, I feel like it's deja vu all over again. In 1994, the government representative came forward and said women shouldn't have mammograms until they're 50. Well, Senator Mikulski called a hearing, and every single woman member of the Senate came and upbraided the government official who was sitting at that table by himself, just like you are, and said, how could you send this kind of mixed message? We have been working for years now to at least get early detection for women, because that's all we've got. We don't have the cure. And finally, after about a month or so after that hearing, the entire NCI cratered. Everybody said, no, 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 40, we really think that's probably the most prudent thing to do. Women should have mammograms at the age of 40. Well, fast forward to about a month ago, and we see the reports of a study that say, well, mammograms are really useless and might even cause harm. And I was looking at that, just astonished that we could be, once again, mixing our message based on apparently trials that were done in 1985. Now, there may have been other